Hi, thanks everyone for joining us again. I'm very happy to introduce Richard Cole, who's a clinical research fellow who's at the outset of a PhD looking at symptom trajectories in traumatic brain injury in the context of autistic traits. And he's going to talk to us about autism and FND.
Yeah, hi everyone. So I'm Rich, I'm one of the BNPA junior reps, and I'm here to talk today about FND and autism. And it's something I first got interested at during my penultimate Core Psychiatry rotation at Queen Square. And I was working on the Hewling-Saxon ward, and I noticed that there seemed to be a high prevalence of autistic traits in some of the patients with FND. And I got speaking to the outpatient FND consultant, Dr. Petropoulos, and her team had already been collecting data on autistic traits, as well as alexithymia and other psychometrics in their outpatient FND service. And we went through this data together, and what we noticed was quite interesting, but I'm going to come back to that a bit later on, as we just had it published last month. But first, I need to make the next slide happen. There you go. But first, some caveats. I'm not an expert in FND, and I'm not an expert in autism either. I'm not here to claim discovery of any sort of association. But what I would like to do is just outline why I think we should be exploring any potential associations and give a summary of what we know so far and discuss what this means for clinical practice, as well as raise some questions for research. Now, at risk of teaching my granny or grannies to suck eggs, I just thought I'd give a summary of what functional neurological disorder is for the people who aren't sure. So this is a condition where the primary pathophysiological process are alterations in functioning of brain networks rather than abnormalities in brain structures. And these alterations result in genuinely experienced motor, sensory, and cognitive symptoms, and often a mix of those. The symptoms arise as a problem with accessing or controlling the body, but the capacity for normal function is present. And importantly, these symptoms can persist and are experienced as involuntary. The etiology is notoriously enigmatic, but we still use, over a century later, this predisposing, precipitating, and perpetuating framework, and I've put some examples of those up on there. And the focus has moved away from that kind of psychodynamic trauma-centered approach, more towards a neurocognitive model with specific focus on alterations in limbic, attentional, and sensory motor networks. And so why look at autism and FND? Well, autism encapsulates differences in emotional processing, sensory sensitivities, behavioral and cognitive profiles, which are all relevant to the way that we look at FND. And the question here is there an association? And if there is that due to core features of autism, or is it due to potentially a autism subtype with particular sensory profiles? Or is it due to common co-occurring conditions? And I've put on this slide some biopsychosocial factors which might be relevant. So thinking neurobiologically, FND and autism both share limbic and salience network alterations, as well as atypical predictive processing profiles, and both have shared altered insular and amygdala connectivity. Looking at the next point, autism is a condition where three constructs relevant to FND etiology are common. They've shared differences in interoceptive profiles, as well as a higher prevalence of alexithymia. And then there's also this sensory over-responsivity. Now, sensory over-responsivity is where people respond for too much or for too long, or to stimuli of weak intensity, often leading to hyperarousal and emotional dysregulation. And it's found in the majority, almost 70% of autistic young people. And it's associated with greater activation of the primary sensory areas, as well as emotional regulation regions, supporting this link between sensory processing abnormalities and regulation of emotions such as anxiety. And patients with FND with waxing and waning symptoms commonly report that sensory experiences such as bright light, loud noises, or pain can exacerbate those symptoms and amplify them. And then when they do sensory responsivity profiles for patients with the FND, there is often a reduced neurological sensory threshold coupled with sensory sensitivity. And then thinking psychosocially, we know that early life adversity and life experiences, as well as trauma, are common predisposing factors in FND, but of course not all patients with FND do experience those. And unfortunately, in autism, there is a higher prevalence of adverse life events, particularly childhood abuse and bullying, as well as adult bullying and domestic violence, which might act as predisposing factors as well. And autistic adults also experience and young people also experience mental health difficulties at a higher rate, especially with anxiety. And there are also co-occurring conditions as well, such as essential sensitivity syndromes, fibromyalgia, CFS, which are relevant when we think about FND, as well as Ehlers-Danlos syndrome, or otherwise known as hypermobility spectrum disorders. And just to touch on alexithymia and interoception, because these are two constructs which are relevant to the etiology of FND and which occur differently in the autistic population compared to neurotypical. So alexithymia is a dimensional personality trait entailing difficulties in recognizing emotions from internal bodily sensations. And it's not inherent to autism, but is found in around 50% of adults with autism compared to 5 to 10% of the general population. And it's a well-researched driver of anxiety in autism, as well as intolerance of uncertainty. And its relevance to FND lies in the fact that patients with FND are more likely to report the physiological markers of anxiety, those kind of markers of hyperarousal, without actually describing anxiety itself. It's a so-called panic attack without panic phenomenon. So someone with FND might experience that fast heart rate, and then they might misattribute that to physical illness rather than that anxiety itself. And then there's also interoceptive differences. So interoception refers to the sensory signaling, the perceptual processing, and the psychological representation of signals coming from internal bodily organs. And much of the research around interoception in patients with FND as well as autistic people stems from this kind of mismatch between interoceptive accuracy, as measured by the heartbeat detection performance, mismatched against interoceptive sensibility, which is your kind of subjective sensibility of internal signals as measured by self-report questionnaires. And the interoceptive profiles of autistic adults and children have been found to be similar to people with patients with functional seizures. And interestingly, Sojko et al. Showed that reduced interoceptive accuracy in FND related to FND severity and integrity of white matter tracts originating from the right temporal parietal junction and insula. And then last year, Professor Garfinkel showed her research where they had looked at interoceptive profiles of autistic people, and they reported an impaired ability to objectively detect bodily signals alongside an overinflated subjective perception of the body's sensations. And so these are some of the commonalities that we find between FND and autism, and factors which might suggest a higher prevalence. But then if we look at what the data actually shows, and there aren't that many studies to present, but first, if you look at some of the population studies, the first one is by Nimmo Smith et al. And what they did is they used the Stockholm Youth Cohort, which is a cohort of young adults from Stockholm between the ages of 18 and 27. And they compared co-occurring anxiety-related conditions between adults with a diagnosis of autism and those without. And what they found was for adults with a diagnosis of autism, there was an adjusted relative risk of 3.42 for somatoform disorder and 6.45 for dissociative disorder. And of course, that isn't the same as FND, but it's relevant to it. And then there's another study by Rudgaard et al. In 2021. They used the Danish National Registry. And what they were interested in is people who'd received a diagnosis of autism in adulthood, what were they likely to be diagnosed with in childhood compared to those who'd not received that diagnosis in adulthood. And they found that people diagnosed with autism in adulthood had an odds ratio of 5.68 for a childhood diagnosis of dissociative and conversion disorders, and 2.99 for somatoform disorder. And then there's this retrospective analysis from the team at Great Ormond Street, and the psychological medicine team there had noticed anecdotally that there was an increased prevalence of autistic traits and autism diagnosis in the young people being referred to them with non-epileptic seizures. And so they looked back through 59 consecutive referrals for non-epileptic seizures, and they found that 16.9% of them had had a diagnosis of autism. And interestingly, that diagnosis was not significantly associated with male gender nor epilepsy status, but was associated with ADHD and tic disorders. And then there are other studies which have measured not autism diagnosis, but rather autistic traits. And they tend to use the AQ50 or the shorter form, the AQ10. And the AQ10 is what NICE recommends is used as an autism screener. So it's not a diagnostic tool, but it can help us know who to refer on for a diagnostic assessment. And if you score 6 and above on the AQ10, then NICE recommends referring on, obviously taken within the clinical picture. And it measures 5 subdimensions of autistic traits, including communication and social subdimensions. And its sensitivity is good, but there's mixed studies on its specificity. But its risk of sex bias is quite low, which is reassuring. And so the first study to do this was by Nestico et al. And what they did, they took a sample of autistic adults, neurotypical adults, and adults with a diagnosis of FND. And they asked them to complete questionnaires, autism screeners, so the autism quotient and another one called the RADS. And they also asked them to complete the sensory perception quotient. And this is a 35-item self-reported questionnaire investigating hyper and hypo sensitivity in the 5 different sensory modalities. And they also assessed them for functional neurological symptoms. Now, counterintuitively, against the population studies, they actually didn't find any significant difference in the results of the autism screeners between the patients with FND and neurotypical adults who are healthy. But what they did find was that when they compared the group of ASD versus neurotypical adults, that the group of ASD had 86.7% of them reported at least one functional neurological symptom, which was significantly different from the 36% in the neurotypical adult group. And then on the sensory perception quotient, they found that hypersensitivity to touch was associated with significantly more frequent functional neurological symptoms in the autistic group, namely functional weakness and paresthesia. And then this was a study that we published last month, myself and Dr. Patrokoulos and Michael, who's our statistician. And what we did is we went through 91 consecutive referrals to the FND outpatient service. And we looked at the results of the autism quotient, as well as alexithymia and other psychometrics. 75% of this sample were female. And what we found was that 40% of the patients scored above 6 or above on the AQ10, meaning that 40% could be considered for referral for diagnostic assessment. So we can't say these are diagnoses, but we can say there was a high prevalence of autistic traits in this sample of 91. And unsurprisingly, 40% scored in the alexithymic range as well. And the probability of scoring AQ positive, so 6 and above, was 31.8% for females and 63.6% for males. And this table just shows how the AQ positive group had a significantly larger proportion of alexithymic, severe anxiety, and severe depression. And then when we did the statistical analysis, it revealed that this group also scored significantly higher on self-report measures of alexithymia, depression, generalized anxiety, social phobia, and ADHD and dyslexia. And those were kind of symptom questionnaires. So again, so not diagnosis of ADHD or dyslexia. I don't think I've got time for that. And then there was this other study, which is published which is in our BMPA books, and it's an abstract from the team down at the IPPN. And they compared 17 patients with FND versus 17 healthy controls. And they didn't find what we found. So they didn't find a difference in autistic traits between the two groups. So we clearly don't have the full picture yet, and the results are mixed, but the population studies suggest an increased risk. Also, given the female preponderance in FND services, there is a higher risk of undiagnosed autism. And we essentially need more data and to look for replication and where the findings extend to non-tertiary FND services as well. Also, we could look at how MDT program outcomes differ between FND patients who are neurotypical versus autistic. And we're also interested to look at the interoceptive profiles of patients with both FND and autism versus just FND alone. And it should also make us think about how we could potentially make the FND MDT program more neurodiversity affirmative. You know, thinking about things like barriers to healthcare that autistic people face. And Mason et al. Published a great review listing some of these barriers, which could be applied to kind of any service. And it would be things like healthcare practitioners' openness to different ways of communicating, consideration of things like slower processing speeds, consideration of things like sensory sensitivities when it comes to bright lights or sounds on wards, but also consideration of factors like intolerance of uncertainty, which is a major driver of anxiety, and how that interplays with things like waiting lists and delays. Also things like investigations, MRI scans, how loud and how confined they are, and what that might be like for an autistic person. And there are potential implications as well for therapies in FND, particularly thinking about the aligning dimensions of interoceptive experience, which is what Professor Garfinkel spoke about last year, where you do interoceptive training and how that helped people, autistic people with anxiety. Could that then be applied within an FND therapeutic framework? I don't think I've got time for this, but this is just a tool that can be helpful for healthcare practitioners. And here are my references.